Welcome to the Healthcare Security Cast, the podcast dedicated to healthcare security, safety, and emergency management. If you are involved with a healthcare security program or desire to be, this podcast is for you. Join the conversation as we discuss the issues that matter to healthcare security professionals while leveraging the expertise of healthcare security thought leaders and experts in personal development. And now, here's your host, Brian Hamilton.
On this episode of the Healthcare Security Cast, we're joined by Thomas Maioli and Sean Fogler. Before we jump into the show, I just want to thank the Healthcare Security Cast sponsors and collaborators. 3D Network Technology, reliability is our core value. Visit www.3dnetworktechnology.com. Genetech, delivering security strategies for healthcare. Visit www.genetech.com. The Change Execution Group and 360 Life Transformations. Visit www.360lifetransformations.com. Canadian Security Magazine. Visit canadiansecuritymag.com. And Omnigo Software. Visit omnigo.com to learn more. And now, let's get into today's show. Welcome to the Healthcare Security Cast for Tuesday, May the 25th. I'm joined today by Thomas Maioli and Sean Fogler. Thanks for joining us, guys.
Good to be here.
Yeah, thanks for having us.
Awesome. Now, I always like to start off by learning about our guests. So I give you guys a chance to introduce yourselves by posing this question. Who is Thomas Maioli and who is Sean Fogler?
That's a question my wife of 43 years is asking quite often. Who is Thomas Maioli? But I can summarize in it. I'm somebody who's from a law enforcement family, has been in law enforcement for over 40 years at the county, state, and federal levels. Spent some time as a professional trainer, about 10 years running training contracts. Had a varied career in law enforcement, did about 20 years as an adjunct professor at some local colleges and universities, and have spent the last 4 years as the executive director of the Pennsylvania Sheriff's Association. And in trying to sort of push the envelope and do some things differently here in Pennsylvania with them, we stumbled onto doing harm reduction training and working on the overdose epidemic here in Pennsylvania, which is severe. And through that work, got to meet Dr. Fogler. So I'll turn it over to him.
Yeah, thanks. My wife asked that question too. And I'm not sure I ever give her a great answer. You know, I have a long story. I'm from Canada, Toronto, where you're from. I'm a person in recovery. Also practiced medicine for over a decade in the Philadelphia area. I was an anesthesiologist. You know, about 13 or 14 years into practicing anesthesia, I myself developed a substance use disorder. And that was that was really rooted in a traumatic experience I had. I was actually at ground zero during the 9/11 attacks at the World Trade Center. Amazingly, I found recovery. My life, improved dramatically. Unfortunately, some of my actions when I, was kind of deep into my substance use disorder gained the attention of the law enforcement community. And I ended up having some justice system involvement, ultimately had my license suspended and was looking for work and something to do that I was passionate about and that was related to my experiences with trauma and substance use and the overdose crisis. And the organization I had worked with had started to partner with the Pennsylvania Sheriff's Association, which Tom, is the executive director of, and that's where we met. And really for a little over 2 years now, this work and the work we're doing together has kind of taken off. So the stuff I do today is, in the public health space, harm reduction, even, touches on the medical community, done a lot of research and, different types of initiatives. And, one current thing is, that I'm really passionate about is because of my experience is addressing stigma, related to the overdose crisis, because I think, that kind of colors everything. And that's in all of our systems, the healthcare system, in the carceral system, the justice system. And I think, that's something that I'm pretty passionate about addressing. So I think I wear a lot of hats and have my hands in a lot of different things, but the highlight of my work has been with the Pennsylvania Sheriff's Association and working with Tom, and so much has come out of that.
Actually, let's start there, just talking about the stigmas. Now, recently, I interviewed a gentleman named Kwesi Millington. So just a little background on his story. He was a former RCMP officer. He ended up actually going to prison. He's since actually has the support of the RCMP in getting his pardon process taken care of. And but while he was in prison, he was one of the situations that he highlighted was having interaction with somebody who used fentanyl. And one of the things that he talked about during his time in there was just really how some of the preconceived ideas that he had as a law enforcement officer really changed after he got to know people. Could you share some of your experiences just in terms of the stigmas around substance use disorder and kind of some of the common themes that you see?
Sure. Yeah, I mean, there's so many different types of stigma, and I think there's structural stigma, the stigma that exists within our systems and the policies, and there's stigma in the public, like these attitudes and beliefs that really have been instilled in people from the time they're children, like really young. These attitudes towards people that use drugs are bad people and they're dangerous and they can't be trusted. And there's self-stigma, right? Somebody that struggles with this disease, like I know really well, the shame and the attitudes towards self are really negative, right? Which causes like a lot of kind of emotional pain and psychological pain, and also keeps people isolated, because addiction is a disease of isolation, and it makes things worse. And the stigma is everywhere. It's really interesting because there's been a lot of research like in the healthcare system, and that stigma is as bad or worse than in the public, which is shocking, right? With healthcare professionals, and I've said this, and Tom knows this, I feel more comfortable speaking in front of law enforcement, who I had a pretty traumatic experience with myself, being arrested. And luckily I didn't go to jail. I spent a few hours in jail, which was more than enough. But the attitudes, and obviously there's stigma within the law enforcement community, but I would say, in the medical community, it's worse. And I think part of that is seeing people kind of cycle in and out of the system over and over again. You see the worst of the worst. People don't, you see the people that don't tend to get better, but the reality is most people do get better in recovery. You just don't hear about it. And the stories we highlight, right, in the news, in the media, they're very sensationalistic, and that fuels things, right? And then it fuels how we talk about people and how we, in healthcare, how we treat people with substance use disorders, because we don't do a great job. And there's a lot of people doing great work and trying to change the system, but it's really tough. It's like trying to steer a huge ocean liner. Like, it's going to take a lot of time, and it's going to take all of us to kind of dismantle that. But until we address stigma, it's very hard to like address the problem, right? Because if your inherent belief and bias is that these people don't deserve care, or they're dangerous, or they're not worthy, then how are you really supposed to do an effective job in treating them and engage with them? Because the reality is people with addictions don't trust us, right? They don't trust healthcare professionals. They don't trust law enforcement, and we have to change that, which is something we're trying to change.
One of the things that we deal with that we point out during our lectures, our classes about stigma, is we sort of turn it around, and police are very stigmatized also. That uniform carries weight with people, and they're automatically judged as somebody would automatically judge someone who has a substance use disorder. So that's one of the teaching points that we use of, you don't like to be stigmatized, so you maybe think about who you're stigmatized. The other thing that we try to push is when Sean or one of our other instructors is up there with their law enforcement training partner, this is a success story in front of them. So they can look at somebody like Sean or one of our other instructors, Samantha is one, who's also in long-term recovery, who had exposure to the criminal justice system. So the cops that are in our class now can say, hey, here's somebody that was locked up by one of my brothers or sisters in law enforcement who is a success story. So not everybody that we arrest comes back out the other side of prison worse. So there's a lot of little victories that we try to show during the 3-hour class that we provide.
That's awesome stuff. Now, the other thing that I'm kind of thinking of here is just in terms of, what you had mentioned earlier, the kind of crisis that we're in right now, and looking at some of the figures, even in Canada, it's the same thing. But in Western Canada was where we were most affected. And, since this pandemic started, it's really been heightened. We've seen a lot more overdoses, and again, I don't have the numbers in front of me, but it's been a really, really steep increase. Have you seen the same thing locally?
Yeah, Pennsylvania has the figures they've released show about an 18% increase in overdose deaths in 2020. Nationwide, I believe it's 22 or 23%. So the pandemic has not slowed this down at all. We're looking to gear up. We have new classes scheduled now. We chose not to do virtual training, but we're doing in-person training. Those are getting geared back up now. And we think when we do get back in the classroom, we're going to hear a lot more stories from law enforcement professionals about this increase and how things have possibly changed too. There's some upticks in other drugs that have maybe not been on the radar because of the pandemic. We just had a conversation with somebody 10 minutes ago regarding fentanyl pills and how you're seeing more of those now in Pennsylvania as opposed to the other areas where they were more popular, such as the West Coast or the Southwest.
Right. Yeah, I mean, overdoses, the CDC, the latest numbers are over 90,000 overdose deaths. For comparison, that number was about 70 in 2019. So that number's, I think ending September of 2020. So it's a significant rise and it's continuing to rise. Like Tom said, there's a kind of a change in what we're seeing. Like we're seeing a lot of stimulant related overdose deaths, especially with methamphetamine and the combination of stimulants and opioids together. So I think it's similar to Canada. Obviously, it's on a larger scale. And the reality is COVID has created an environment that is, not good for somebody with a substance use disorder, right? Like recovery to me is all about connection, and COVID has caused us to disconnect. And obviously has heightened, anxiety and stress and, employment issues and homelessness and all the other things that feed into it. And so, we have a perfect storm, and the reality is a lot of our strategies are Band-Aids. Like naloxone's a good thing, MAT's a good thing. Like a lot of these things are really good things, but in and of themselves, they're really Band-Aids. Like we're not really addressing the underlying issues, which obviously is a big conversation and there's so much involved there. But until we do that, and part of that conversation is stigma and attitudes, right? And addressing those. But this crisis is really escalating. And the other thing that people aren't really talking about is alcohol related deaths. Those are skyrocketing. And, that's a significant, and, alcohol kills more people than opioids. We don't really talk about it, but it's a legal drug, right? So it's looked at differently.
One of the things that we try to stress in our class, and I've learned this as a trainer, is to make things personal and try to have the student relate to the subject matter on a personal level. And with the opioid and overdose crisis being what it is in Pennsylvania, in every class of law enforcement officers that we have, there's going to be a personal connection to the overdose crisis. And that one of those officers in there is going to have somebody in their personal life who is suffering through substance use disorder. I have it. Other people I know have it. So we try to train them not just on what they can use when they put the uniform on, but what they can use when they go home, and to try to better understand stigma and just substance use disorder in general. And I think it's been effective. Our program has gotten great reviews. We've worked with our research partners at the University of Pennsylvania. Been some papers out on it. So it's working, we think. That's why we're really excited to get back out and do more classes and maybe spread the word throughout the country that it's a viable program. And police officers need to understand harm reduction, and they need to sort of soften their heart a little bit maybe. And most cops that I know will listen, and they'll do what's going to make their job easier and make themselves more effective. And we start classes with, the typical cops are in the back of the class with their arms crossed, and 9 times out of 10 by the end of the class they're participating, and not because of my skills as an instructor, I know that, but just maybe Sean's skills, but just because of the subject matter, and they get it. You can see the light bulbs turning on, and if they buy into this, they're going to see that it is going to make their job more fulfilling possibly. because we always use the adage or the story that, when everybody got on the job, and I know when I did my interviews, why are you here, kid? Why do you want a job in law enforcement? I want to save people. I want to save lives. And in your mind, you're thinking, I'm going to pull somebody out of a burning car, when in fact, you may be putting somebody into treatment and saving their life that way, maybe deploying Narcan to save their life that way. And a life save is a life save. The circumstances really don't matter. It's just that self-fulfillment that you get by providing those kinds of services.
Yeah, I think that's a critical point, because frequently somebody with an addiction, people point their finger and it's those people, it's the person under the bridge on the street. The reality is it's us, it's doctors, it's lawyers, it's law enforcement, it's people in finance, it's people from every walk of life. Like, this impacts all of us. And I think that really comes out in the training, and is a really critical point, because, this is all of our problems. It's affecting our families, our communities. It's everywhere, and it's escalating.
No, absolutely. Now, if I'm to share, my personal experience, individual who I grew up knowing as my, my half brother, essentially. It was only when he passed away, and just given family dynamics, it gets kind of convoluted if I, explain the whole scenario. But it was at his funeral where I found out he wasn't actually my half brother. My dad had raised him for a good portion of his life. He called my dad. But when I was 10 years old, he ended up being stabbed over $20 worth of crack cocaine and died. Right now, for me, you would probably assume that somebody like in my scenario would have had a softer heart towards people, dealing with these issues. And, it was the opposite. I kind of took more of an adversarial stance towards this dealer, right? And anybody who was really involved in that lifestyle. So, and I guess the question I want to ask, just based on that, is for the individuals who, and again, it's a lot of us who, look at those stigmas and I guess have a negative mindset towards people who are struggling with substance use disorder. What are some of the things that you're teaching to help, I guess, reframe that mindset?
Well, from the law enforcement perspective, you were teaching it as a way to be more effective and more efficient. Get more friends on your side in other ways, and otherwise, and law enforcement needs that more than ever. People that understand what they do, that are willing to help them out, and that's a big effect, I think. It will make your job easier, I think, if you understand this disease. And I spent a lot of my career, a bunch of my career, doing law enforcement intelligence and drug intelligence, and a lot of my sources were doctors and people that are in rehab centers. They were great places to go to hear about what is next. So I guess the point is to try to open your mind a little bit, to look for information and look for people that can help you in areas maybe you wouldn't have normally looked. And I mean, my father was in law enforcement forever, and he used to always say, you catch more bees with honey than with vinegar. And why not try it this way? I mean, I've been involved in law enforcement since the 70s. I mean, my first drug arrest was an accidental one. I was looking for somebody, and I found somebody else who was carrying a bunch of very bad heroin with them, 2 to 5% pure. And it's evolved to this point now in the system. The issues are still out there. The product is much better and much more dangerous. But we're trying to sort of shift the paradigm here and look at different ways to do a difficult job. And if you can use harm reduction, if that's something that's in your toolkit, by all means use it. And I think most law enforcement officers will do that. That they're looking to get through the day as best as they can and be productive. And if they can use these tools that we try to teach them to get through that day and to be more effective, I think they'll readily accept them. And we've seen that in our classes.
And I think one of the things we do is teach them to see addiction as a disease and to humanize it, and to understand it's really no different than diabetes, or these other diseases, even though we look at it differently and we treat it differently. But understanding that, frequently can kind of change the mindset, and like understanding what's the driver of the behavior. Because like for me, my experience, and for many, I think with substance use disorders, it's a lot about trauma, and pain, either physical pain or psychological pain. And that's like an important kind of message that underlies it. Because I always say, Addiction has nothing to do with drugs. And a lot of people will look at me and be like, what are you talking about? And I'm like, that's not what's driving people. It's not that they just want to have fun and they want to break the law. Usually, most of the time, if you really have an addiction or a substance use disorder, you're medicating something. You are not comfortable in yourself. You're not comfortable with your emotions, with your experience, maybe things you suffered as a child or whatever it is, something that happened later in life. And it's really somebody trying to get outside of themselves, and understanding that frequently, kind of creates a shift. Wow, this person's sick. Wow, this person they were traumatized as a child. They, don't have a home. They can't support their family. They have a cycle of trauma that they're just repeating. And understanding that, I hope, and I think it is happening slowly, is, everybody's kind of softening. Like when you get that, when people become empathic and have that compassionate, see it, their hearts open, then their minds kind of open. They're like, wow, maybe sending that person to treatment or providing that person with resources and skills and strategies to protect their health and their life until they're ready. Maybe that's a better way, right? Because a cage isn't really an effective, I mean, for some maybe, but for the vast majority of people that struggle with this disease, it's not helpful. So I think we have to do something different.
It's at times it's not an easy sell, and you have two people teaching here who come from very, very different backgrounds. Sean and I, and and our other instructors are, one of our other instructors teaches with someone else who's in long-term recovery, and people that worked with him had arrested her back in the day. So you have this sort of dichotomy up there teaching to try to balance each other out. That's one of the big differences in our program from some others, I think, is it is co-taught by somebody in long-term recovery, a treatment professional, and somebody in law enforcement who's had a lot of drug enforcement experience. So it creates a nice dynamic, I think, when we do teach it, because we come at things from different angles, and sometimes our politics don't match up, but we know that we're there for the right reason and can sort of balance it out.
Yeah, I think the goals are common. Like what we're trying to accomplish is the same thing, and allowing people to see different sides or see the world, I guess, through our different, lenses provides like a really kind of rich experience, and it stimulates discussion. Sometimes pretty fiery discussion in certain crowds. Like we were at the Pennsylvania Wardens Conference and we had some heated discussion, but I mean, I think that's like a path to change, if you can have those conversations, respect each other, and just start to think a little bit differently. Because I've learned a lot from Tom, and with all the law enforcement training, like seeing the world through a totally different perspective. And I have more compassion and empathy for what they do and their work as well, right? Which before I was like, oh, they're just trying to destroy me, and assassinate me. And, as my lawyer said, like early on when I was charged, he's like, they want to bury you under the prison, and I was like, and so, but my attitudes have evolved too. But I think we have, for the most part, the same goals, and working together is it's a powerful combination to see kind of both sides. And I also think my background in healthcare is also unique too, because there are a lot of similarities and overlaps between the two in terms of like attitudes, beliefs, strategies, which is, I found very surprising, but they're the same, and in some ways, like our attitudes towards drugs and people that use substances, from the law enforcement or carceral kind of, direction, have also been absorbed into our healthcare systems. And so the people that are working in those systems see those people the same way. And I think that's part of the reason why we have trouble, right? Like managing people with substance use disorders in our healthcare systems. And that's something that obviously needs to change, and is going to take time.
I've learned so much from working with Sean and working on this program. I can just hope that the cops in the audience pick up a little bit changed my thinking on a lot of things. Just, getting to know Sean, getting to know the other people in the treatment community, and to realize that our goals are so similar most of the time, to just save people's lives until they can make their life better on their own. That last dose of Narcan that brought them back may be the one that changes their life. One of our other instructors tells a story about how the last time she went to rehab was with a police officer. He took her to rehab. He could have violated her parole, but him and her probation officer decided to give her one last chance. And she's been a tremendously productive citizen ever since. Master's degree. She was one of my students in undergrad. Master's degree. We just got off the phone with her, as a beautiful family and a beautiful life. And a lot of it she traces back to that police officer, just that last time helping her out. And he didn't have to, but he did, because he had that ability to do that, and had it in his heart to do it. And we're just hoping that we can train other cops to be that way.
Right now, Sean, when you were going through your substance use disorder, and on your path to recovery, what was it like when you were dealing with your peers, I guess, other medical professionals and the law enforcement individuals who were obviously aware of what you were going through? What was some of the backlash that you went through?
Well, I mean, while I was kind of in it, I mean, I practiced a specialty, which in some ways is a little bit isolated. Like, yeah, you work in a team, but I wasn't using substances at work, obviously, but I was still impaired, right? Because I was using outside of work and then coming into work. And I wasn't using the substances that I worked with, right? I actually wasn't using, opioids. So for me, like, that was a line of safety, which is ridiculous, right? I mean, that's like the disease talking. And so I did my job, and I actually did my job really well, which, is kind of like, was not a very good thing, because it allowed my addiction to escalate and the problem to get worse, but I could hold it together at work, which I think a lot of, physicians they're kind of masters at that, right? They can hold it together. And in medicine, there isn't a culture that encourages you to come forward and ask for help, right? Asking for help is a sign of weakness. You're supposed to have all the answers. If you do come forward and disclose, the consequences could be catastrophic. So people keep it hidden, and that's the most dangerous place to be. So, at work, there was nothing. And I had no idea law enforcement was interested in me. And, I went away to rehab in May of 2015. And this was, things were not good. Things weren't good at home. My wife was basically ready to pick up the kids and take off. And I was like, what are you talking about? I mean, that's how disconnected from reality I was, and how little insight I had. But it was enough that scared me. Like, I remember that conversation with my wife in the kitchen, like holding my son, who was like 2 at the time. And that was enough to scare me. And I went away. I went away for 4 months, really kind of changed my life entirely. Came back, threw myself into recovery, started working, and actually was in the process of changing my specialty. I actually had started a fellowship in addiction medicine. And that's when I was arrested. So I was about a year and a half into recovery. And then I was arrested, for drug-related offenses, and some prescriptions I had written in 2014. So that was in 2016 in the summer, a month after I found. So then I knew the law enforcement were very interested in me, which was shocking. And especially like having been in recovery, I was like, wow, like so many good things are happening. And that was like really traumatic and hard. But I mean, it's the consequences of, my actions in the past. And that dragged out for 2 years, which was real, that was a painful time. That was like a really dark time. But luckily I was in recovery. Luckily I was connected to a strong recovery community, because the reality is, like, I don't know how I would have survived. You hear about people, they're deep in their substance use disorder and they get arrested or they go to jail, and that's the impetus. Like, I had already, was well on my way, and that was hard, and I don't know. I've just kept plugging forward, and I'm trying to do good work and just kind of continue moving forward and not dwell on the past. But I mean, it's been a challenge. It's been hard. And working with Tom initially was hard. I had a lot of, hesitancy about working with law enforcement, but I'm really happy how things have turned out. And, I'm thinking, there's so much we can do down the road. So I think I'm rambling a bit, but, but yeah, I mean, it's been quite a journey. Yeah, an interesting road. And
the first time Sean and I met, we attended a meeting together of some very high level drug people in the Philadelphia area from various federal agencies and state agencies. And halfway through the meeting, an individual stood up and said, "Sean, you don't know me, but I led the team that charged you and convicted you." It was just happenstance that he happened to be there, and he congratulated Sean, and it was heartwarming to him to see Sean in that position. So that was his sort of birth by fire back into the welcome to the law enforcement community, Sean. That guy over there was the one to put the cuffs on you.
First of all, I was scared going to the meeting, right? Because Tom's like, well, there's going to be some different groups there. There might be some people from the DEA and I was like, oh my God, really? And so they asked us to give a little background of the program, and I start talking, and this guy points at me, and I look at Tom, and Tom looked a little bit like, and he's always very cool, like nothing phases him. And I mean, I hadn't known him for that long, but he was definitely a cool customer, and he looked a little bit stunned. And then I was like, wow, what, like, this is, and it turned into this we ended up having a very kind of open, honest discussion. There was a DEA officer there who had lost his son, right, to overdose, which was, and it's almost like that event kind of opened up the floodgates, and all sorts of people started, sharing about their experiences and things like that. And it was pretty transformative and amazing. I was pretty blown away and shocked and stunned and scared all in one.
One of the things I enjoy is exposing Sean to the law enforcement community, in a positive way, because it's the community I grew up in from my dinner table to now. I've been blessed to be a part of it, but sometimes there's still that sense of awe that comes over him when he sees how we are actually. And I know I've told this story before, but we had finished a training at a law enforcement site, and as we were leaving town, we stopped into a local coffee shop, and the woman said, "Where were you guys at?" I said, "We were up at the college, teaching law enforcement." And she looked at me. It's before the pandemic, so I didn't have a mask on. She goes, "That indicates anything?" And she said, "Are you in law enforcement?" I said, "Yeah, I'm retired." She goes, "Well, your coffee's free." And she turned to Sean, and she goes, "Are you in law enforcement?" He goes, "I'm a doctor." She goes, "Your coffee's double."
No love anywhere.
Oh, that's a great story. No, just in terms of the course offering, the training that you guys do, one of the topics that you kind of discuss is medically assisted recovery. Can we unpack that thought a little bit?
Right. Yeah, absolutely. I mean, when it comes to opioid use disorder, medications are a powerful strategy. There's loads of evidence that show that they reduce morbidity and mortality. People get their lives back. They do amazing things. There's been a lot of stigma towards those medications, right? Are you trading one drug for another? If you're on a medication for your opioid use disorder, does that actually mean you're in recovery? Like, even within the recovery community, there's a lot of negative attitudes and stigma towards these medications. And it's ridiculous, right? Because these medications save people's lives. And methadone's been around forever. And, and Suboxone obviously is a newer drug, but Suboxone in the 90s in France, any doctor was able to prescribe it. And overdoses went down by 85%. Thousands more people went to treatment. There's all sorts of, data from around the world, and now, within the US, but these stigmas still exist, a fraction of, and part of the problem is the way we prescribe, at least in the US, methadone's distributed in these federally, approved centers. People line up outside early in the morning. Like, talk about stigmatizing, right? You have a disease, we have a medicine for it. We're going to make you line up outside a building every morning that everybody knows is a methadone clinic. And you're going to get shamed and judged and look at those people. And yeah, sometimes shady stuff goes on around the methadone clinic, but it's a horrible way to get your medicine and get your disease treated. And with Suboxone or buprenorphine, you need a special waiver. And some of those restrictions are being lifted in the US now, but the waiver still exists. And just the method, like if you think about it, any doctor with a DEA license in the United States can prescribe you as many Percocet as you want. But when it comes to a medication for your opioid use disorder, like Suboxone, you need a special waiver. You can only treat so many patients. And that's mostly because of stigma. It's not a safety thing. These drugs are actually safer than traditional opioids. Methadone can be dangerous, but medication's a powerful strategy, and more and more people are treating it. But the reality is, even within the medical community, very few doctors are waivered. The doctors that are waivered aren't using that waiver very much. And the reality is they don't want to treat this patient population because they think they're dangerous, they're manipulative, bad things are going to happen. And obviously law enforcement has, over the past few years, has really focused on overprescribing and diversion of drugs, which was a massive problem, is still a massive problem in some different ways, right? Things have improved, but there is still diversion and things like that. And so like, it's kind of a perfect storm, right? Like they don't want to deal with these patients at baseline. They're afraid of enforcement. Doctors do get locked up regularly, many for doing, horrible things. And so it's complicated, but medication's a powerful strategy for recovery. And if people want it and they're willing to get on it, and there's some different forms now, there's an injectable form. Like we were just talking to a jail that was concerned about, diversion in the jail. And there have been studies on diversion. And the reality is most diversion is to treat opioid use disorder. It's because the system we have doesn't allow enough access, especially in rural counties where it's very limited access to a doctor that would prescribe that medicine. So people aren't getting treated. So they're trying to find a way. But a lot of jails are concerned because typically it's, the medication's given by a strip or a tablet. And so there's an injectable form. And we were talking about it to a jail recently that may be interested in doing that, one injection every 30 days. And it's a great thing. It makes jails safer. It gets people into recovery. It prevents recidivism. I mean, there's so many benefits to it, but we still have these attitudes and this mindset, right, towards people that are suffering with this disease and are being treated with this disease.
If you can show somebody, and the wardens, we've been dealing with a lot of wardens lately on this. If you can show them that it's going to be effective, in the long run, it's going to help the people in their jails. It's going to save money. I mean, it's all about the Benjamins, right? If we can show that it's going to save money, that's going to get people in the door and get them started on it. We've been very fortunate. We've been working for the last couple of years with Vital Strategies, which is a group that works for Bloomberg Philanthropies. They've been our major grantor and helping us with this. Very great to work with, and that's been a positive experience. Also been working with the Pennsylvania Commission on Crime and Delinquency to distribute naloxone and provide subject matter expert work to the 62 county jails in Pennsylvania, and if needed, to our State Department of Corrections. So the association's been very fortunate to have those partnerships and be able to put some good work out there through folks like Sean and some of our other instructors and consultants.
Now, are there ever any concerns for individuals maybe responding to an emergency related to a substance use disorder? Do you ever see hesitancy to, maybe intervene? And if so, are there any laws that protect people who would intervene? Because I think, if that is a challenge, people might just have fear of, later liability or repercussions for trying to help somebody and maybe potentially making things worse or still getting a negative outcome.
I'll handle part of it and Sean can handle the other part of it. I don't think, I would like to believe that 100% of law enforcement officers are going to do their job when called upon. I really believe that in my heart. There may be a few out there that wouldn't, but I have a hard time handling that. But I think most of them, all of them, are going to be willing to step up and do what's needed. Every day that happens. You just don't read about it in the paper. About cops that do put their lives on the lines and deputies that put their lives on the line every day. So I think they would respond. This class even helps them fine-tune that as far as using naloxone and channeling people. And we also have in Pennsylvania Good Samaritan laws that Sean is very familiar with that can talk about. Who could talk about? So
Yeah, I mean, one of the hesitancy, and it's really lack of knowledge, law enforcement and the public. People don't really know that they're protected, right? And these Good Samaritan laws, I think there's 48 jurisdictions in the United States, because I was just looking at this for our policy statement. 48 jurisdictions in the U.S. that have Good Samaritan laws, that when people respond to an overdose, and usually you have to stay with the victim, you have to call and report it, and there's like certain criteria. But if you go and you respond and your intentions are good and you're trying to help, you are protected. And that usually means you're protected if you have drugs on you, not distribution, but possession and some, minor related offenses. And many people don't realize that. And there is some, research. I remember there was one study in New York, and the reality is most people that did not want to call 911, it was fear of police and fear of prosecution. But
Right.
when people learned about these laws, the response rate went way up. People started calling, the vast majority of people. But there is hesitancy in the community, even with these laws. But I think we need to work harder to educate. And one of the things our training does, we talk about this, right? We talk about the Good Samaritan law, how it applies to them, how it applies to the public, why it's important. Because that's part of the solution too. People need to know they're safe, because typically when people are using drugs, they're around other people that are using drugs, right? And so we need to educate them and equip them with the knowledge and the strategies to act to save lives, which is a bit of a shift, because typically it was always, we have to do this for our first responders, but what about the general population, right? Because they're frequently going to be there first, and it takes time for EMS to arrive on the scene or for police to arrive on the scene. And if somebody's there and they have naloxone in their hand, we want them to act.
Sean just did some training for us at our last conference on the Good Samaritan law, and we're about to issue a policy statement from the association, sort of outlining what the law is and expressing our support for the law. So we think that's a positive step forward too.
Right. And we had, in regards to your last question on medication-assisted recovery, the Pennsylvania sheriffs, I can't remember when we did that, but we put together a policy statement on opioid agonist treatment in correctional settings, which is the medications that we were speaking about before, and their support of that, which is in line with the National Sheriff's Association and the American Society of Addiction Medicine. I mean, the reality is, in many of our prisons, people are suffering from addiction at very high rates, 70, 80. I mean, we heard 90% in one jail recently, which is massive. So we need to treat the disease, right? Not treating it, is just, I don't think it's an option. I think it's been an option in the past, but it's not an option because the consequences are too high, right? And the costs are astronomical.
Absolutely. Now, in terms of the response to these incidents related to substance use disorder, one of the things that could be a concern is communicable diseases. Is that something that is kind of part and parcel to these type of responses, or is that more of a stigma?
It's something that law enforcement's aware of. One of the things we teach in our class, we show statistics as far as communicable diseases, hepatitis C, B, right?
B and A,
yeah. and HIV, and how syringe exchange programs can cut into that. Not normally the easiest program to put out there to law enforcement, but we want them to know what's going on in the field, how syringe exchange programs work, and how it's going to affect their lives and possibly keep them safe. All every cop wants to do is go home at the end of his or her shift. And if syringe exchange programs can work along those lines and help them, we feel it's important to give them the facts on that. And that's what we do. We talk about the programs that are being used here in Pennsylvania and the statistics aligned with those and their effectiveness.
Yeah, I think, we've made a lot of progress over the years around communicable diseases related to drug use, but over the past few years, things have started to escalate, and especially in certain regions of the country. Especially, fentanyl is a short-acting drug, so people are tending to inject more frequently versus, heroin from back in the day. And that's, changed things, and needle exchanges or syringe service programs. And I hate the name because that's like one small component of what they do. They're really, hubs of health. Like, it's an access to healthcare for really vulnerable populations. And so, educating people on that and how that can be a powerful strategy to health and also a pathway to treatment, right? Like, that's where people get educated on strategies like naloxone or medications, or find the opportunity, to go into treatment or get tested for hepatitis or HIV. I mean, they do so many things, and the human connection too. That's probably the most important, because I think a lot of these communities that have been oppressed, that are marginalized, that kind of live in the shadows, they don't have a place to go, and they feel very disconnected from society, communities. They don't feel loved, supported, respected. And I think these programs can serve a role in that, which is really important, and humanize people again, like, give them some self-worth back, give them some hope, because hope is a really powerful thing. But, when people are deep in their addiction, I mean, you're not thinking about hope. You're thinking about survival, and, most, don't think they're going to make it to tomorrow. And so, a place like a syringe service program or some of these harm reduction strategies can really be transformative. And we teach that, we talk about that.
Now, I have another question for you guys. Now, obviously, you have a lot of experience in your respective fields. Tom, if you knew what you knew today, back in the 70s when you first started in law enforcement, how would that have, shaped how you conducted yourself as a police officer? What would have actually changed based on your current knowledge?
I probably would have looked at people maybe a little bit differently. I don't think I understood that substance use disorder was a disease. I don't think I grasped that quite as much as I should have. I looked at people. I tried to treat everybody the same, okay, and just from a moral perspective, and also from the perspective of I was always looking to develop people as informants and sources of information. So if I treated them decently, maybe they would help me. So maybe it was a little selfish in that regards, but it was pragmatic also. But I hope that if I could run the tape back and look at how I treated people back in the 70s and 80s, it would stand the light of day. I was involved in a federal task force back in the 80s that dealt primarily with powder cocaine, coming out of Miami. So we were dealing with those kinds of issues there, but it was a different ballgame then. It was much more enforcement led. I mean, we weren't dealing with people who had addiction issues. We were dealing with more higher level, mid-level dealers. So we were, aggressive, professional, but aggressive. So I don't know if that would have changed my ideas back then or not. It might have. And I would have definitely, took the phone call from Steve Jobs when he wanted me to invest in this little company called Apple that he had. Probably would have taken that phone call,
Fair enough.
Great. That's great.
and Sean, for yourself, if you could, again, go back in time and visit Sean Fogler, back in the early point when you were, kind of in the middle of your substance use disorder, what would you say to yourself?
Ask for help, reach out. I just, and it wasn't just like my medical training or the medical community, because that's, that is instilled in you, but it started when I was a child, like I learned that from my dad, really. You just, you don't ask for help, you got to shoulder it all the time. And it's like a horrible way to look at the world, and not to cast blame or anything, but that was in my mind, that like asking for help, reaching out, it wasn't even an option. It didn't even cross my mind. To give you an idea of how like kind of disconnected I was from reality, and scared. But I was so, I guess, dissociated or I didn't see it as an option. And I guess I didn't think it was safe. I didn't think about it too much. I think I was just on autopilot, which I think many people with this disease, if it gets bad enough, you're just trying to survive and keep walking forward. And like as a physician that, was getting paid very well in like a specialty, like to the world, I looked a certain way, right? I successful, like I had lots of friends. I mean, nobody had any idea. My wife obviously had some inklings because my behavior was not, I don't know, quote unquote normal, right? Like there was something up, but she didn't even really know what it was. And I wish, like I say, I say this pretty regularly, like I wish that somebody would have seen something or somebody would have acted, or I had the courage to ask for help. And then I would have had a chance, right? Like I would have had a chance to kind of get back on course, but I didn't. I mean, it happened the way it did, And the twist is that like I got into recovery and was well into recovery before kind of, the avalanche kind of fell down. But I came out of that too, unbelievably, with the support of, family, my community, with people like Tom, like the work, because when we were talking about stigma earlier, people talk about like storytelling and education and how important that is. And it is, but does it really change anything? Not much. I think what changes things is like a relationship like this, where people that have been impacted are working with people that maybe normally you wouldn't be working together, right? Would be from two opposite sides. And like, that's where change at. People see that. They're like, wow, that's pretty amazing. And they see somebody in recovery and they see somebody doing, work to kind of change the narrative and make things better. Like I think that's a powerful message. And, like we talk about that, but it's a really powerful message, and it's healing too, like for me, right? Because when you've been like hammered by the justice system, it can be very dehumanizing and, crushing, like real traumatic and painful, but this helps a lot. So, yeah. Now I'm getting emotional. God.
No, and thank you both for sharing that, because, my hope is that somebody who's listening who may be going through what you were going through then is able to get some help from that. So I appreciate you being willing to go there and share that.
Thanks. Yeah. Thanks for creating a space, for us to talk about this, because that's powerful.
This whole program has been, I know it's been good for Sean, but it's been great for me. I'm sort of toward the end of my career. I hope in some ways.
He's never retiring. He keeps saying he's retired. This guy works more than anyone I know.
But it's been a real blessing to be exposed to a whole different community and to learn. I mean, the way you grow is to keep learning. I think the way you stay young is to keep learning new things. And boy, if I learn something new every day dealing with this subject, and it's really opened my mind up to quite a few different things that I really enjoy doing. It's been, I like training. I like training with Sean and the other folks in the program. I like to think that I'm giving something back to the law enforcement community because it's given so much to me and to my family. I mean, as I said, a whole, generations of Maioli. Thankfully for crime, the Maiolis would be living under a bridge right now without crime, probably, a couple generations of us. But yeah, it's nice to hopefully I'm giving something back. And it's nice to have had the opportunity, as I said, at this stage of my life and my career to do that. And hopefully to do it for a little while longer, at least.
Awesome stuff. Now, I know we hit on a lot of different topics. Is there anything else that we maybe didn't cover that you guys would like to discuss further?
I can't think of anything. I think we've hit everything. We're looking to grow the program. We're doing a seminar at the National Sheriff's Association in Phoenix in June, which is a true honor. Sean and myself and the president of our association, Sheriff Jim Custer, who's a longtime law enforcement person who's gotten involved in this also. So we're hoping to put the word out there that it's a viable program, and we're willing to help anybody, any state, start their own program, come out do a train the trainer program. We're actually hoping to be doing that soon. We got a grant. We're about to get a grant from a pharmaceutical company to put us out there to do a train the trainer program and train a lot more Seans and Toms to get out there and spread the good word on this, on harm reduction.
Awesome. And for anybody who wants to know more about, the things that you have on the horizon, if anybody wants to, get involved in one of these train the trainer programs and roll it out in their state or what have you, how do they get in touch with you?
They can get me through our website, which is just pasheriffs.org, or email me. I'd be more than happy to give out my email address here. It's tmaili@pasheriffs.org. And more than happy to get in touch with, if they get in touch with me, to tell them about our program. Actually, our slides are up on our website that they can look at and see if it's a fit for their jurisdiction.
Yeah, and for me, Sean, SEAN at Elevist, ELEVYST, and elevist.com is the website. We're a public health consulting group that does work with law enforcement, healthcare professionals, advocacy, and a number of other public health related issues. Yeah.
Awesome. Now, do you have a special message that you could share with the Healthcare Security Cast community before we wrap up today?
Yeah, I mean, just keep learning. I've learned a lot over the last 3 years, 2.5 years, and you can teach an old dog new tricks. And in law enforcement or in healthcare, I think. So just keep learning and keep your mind open to different ideas.
Yeah, I would agree. Learn, grow. Change is a good thing. Change is uncomfortable, as I know very well, but it's a really powerful thing. And when you get comfortable being uncomfortable like that, a lot of great things can happen. And I think collaborative solutions, especially with like unexpected partners, can be super powerful. And I don't think, we like to, and I talk about this all the time, we like to work in silos and very fragmented systems, and everybody's kind of doing their own thing and sometimes pointing the finger at each other and casting, judgment, but together is the solution, right? Like that's really, really powerful. And even working together with people that have very different views or mindsets, if your ultimate goal is the same, you can do a lot of amazing things. And we're doing that. We're doing that. We're making that happen.
Awesome stuff. Well, guys, I appreciate the time. I appreciate you sharing all this information. And I think it added a lot of value. So again, thank you for that.
Thank you.
Thank you so much.
The Healthcare Security Cast is available on Spotify, Apple Music, Amazon Music and Audible, and many other platforms as well. Check out our link tree on your computer or mobile device. And this can be found at linktree/Brian Hamilton. That's linktr.ee/Brian, BRINE Hamilton. Again, that's linktr.ee/Brian Hamilton. Or if it's easier, send me a text at 647-372-2042. That's 647-372-2042. And I'll be happy to answer any questions you may have or share any links you may be looking for. Thanks again for listening. Until next time, take care and stay safe.